So for our clinical predictions assignment, we had to first read through the Adams article and then find a CPR of our own and go through it with using Zoom and a voiceover. So the couple things that stood out to me with the Adams article were I first wrote down like what a clinical prediction rule was, like the formal definition for it. And their clinical prediction rules are mathematical tools that are intended to guide clinicians in their everyday decision making. So there's 5 different types of models, and each one of those like in some way help a clinician make a more accurate assumption of what's going on with the patient. There are 4 phases of establishing a clinical prediction rule, and the first phase is development. So it's identification of predictors from an observational study. The second one is validation. So it's testing of the rule in a separate population to see if it remains reliable. The third is impact analysis, and it's a measurement of the usefulness of the rule in the clinical setting in terms of cost benefit, patient satisfaction, time, and resource allocation. And the fourth one is implementation. So it's then widespread acceptance and adoption of the rule in a clinical practice. The 5 types of prediction models are, first of all, the scoring system, which is the one I picked. I picked a CPR that uses a scoring system, and its factors shown to be significantly related to the outcome in observational studies are scored or weighted. The cumulative final score of all the risk factors present in a patient is used as an indicator of the likelihood of the outcome occurring. Well-known examples of this are the one I actually use, Alvarado score for acute appendicitis, and another one is a modified Glasgow score for acute pancreatitis. The other ones are prediction models based on multivariable analysis. Another one is nomograms. The fourth one is prediction using artificial neural networks, and the fifth one is decision trees or CART analysis. So the CPR I chose is called Alvarado score for acute appendicitis. It's basically a list of questions that calculate your likelihood of acute appendicitis based on symptoms, signs, and lab data. So when to use this would be any patient with suspected appendicitis, typically with right lower quadrant abdominal pain, could take this test just to get a better idea of what's going on. One of the downsides of the Alvarado score is that it requires laboratory results or laboratory data in addition to history and physical exam findings. So now we're going to go look at the Alvarado score system, and we're going to go through it like we're actually using it. Okay, so this is the Alvarado score for acute appendicitis. As you can see here, there are signs, symptoms, and laboratory values. So we're just going to go through and we're going to click yes or no if we have something that matches up with this. So right lower quadrant, tenderness. So just using this as an example, let's say I have that. Elevated temperature, no, not really. Rebound tenderness, sure. Migration of pain to the right lower quadrant, okay. Anorexia, no. Nausea or vomiting, okay. And then leukocytosis greater than 10,000, okay. So just as using as an example, I went through and I clicked yes or no for these questions, and it calculated my score, and I got 7. So probably / likely appendicitis by the Alvarado score. This is just a quick, pretty easy way to help clinicians make a potential diagnosis. Clinical prediction rules, I think, are pretty important because they can help the clinicians think of other factors that they wouldn't normally consider or that maybe have slipped their mind at the moment. The Adams article states that they've been proven to be pretty helpful because the human brain can't comprehend or can't think of all the symptoms that, or all the ailments that could be happening to people based on a certain set of symptoms.